Hello, everyone. Welcome to the National Grand Rounds of the Canadian Association of Emergency Physicians. Our session today is hosted by the Anti-Racism and Anti-Colonialism Committee. My name is James Liu, and I'm here with my co-presenters, Taylor, Dupuis, Shalovsky, and Kelly Soros. We'll be introducing ourselves and acknowledging the territories where we're located momentarily. We'll be exploring the topic of putting reconciliation into action in the emergency department. Our learning objectives for today are to differentiate between overt and systemic racism and to remove individual visceral reactions to anti-Indigenous racism as a way to further dialogue on anti-racism strategies, as well to highlight the importance of relationship between healthcare providers and Indigenous patients to ensure meaningful assessment and treatment, to demonstrate examples of healthcare disparities between Indigenous patients and non-Indigenous patients, and to provide tangible action items to decrease these disparities. And finally, to discuss options for emergency department access to Indigenous specific services. We have no relationships with financial sponsors to disclose. Our program today has received no financial or in-kind support, and we have no conflict of interest to disclose. Each of our speakers have reviewed and completed the declaration of conflict of interest. We'll now hear from Kelly, who will introduce the vision, purpose, and format of our session.
Hi, everyone. Thank you, James. Thank you, everyone, for coming. My name is Kelly Soros. I am Métis. My maternal grandfather, Edwin Bulmore, was born in the Red River. We're from the Red River, and then our family went to Capel Valley. I'm also Norwegian from my father, Ross Soros. I practiced urban emergency at St. Paul's Hospital in Vancouver and rural family medicine in Gitxsan Territory in Hazelton. I'm so happy I'm presenting to you today from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. First of all, thank you so much for coming. I want to recognize that we're going to talk about 3 cases, and they're real cases, and they come from personal experiences as healthcare providers. The subject of the talk, it can be hard, and hopefully it does evoke some emotions. I'm asking you to remember the difference between being unsafe in a learning space and feeling uncomfortable. I would ask that you choose to lean into any discomfort that you feel, as this is where we can make meaningful change. Today, we're mostly focusing our talk on systemic racism. There are some examples of overt racism, but overall systemic racism, it is what is harder to name and act upon. Our healthcare system was built on white supremacist ideologies, which are pervasive today in how care is delivered. You do not have to be overtly racist to uphold white supremacist values, and you only have to exist in the system. In order to combat systemic racism, you must name it and then actively oppose it. This takes vigilance and bravery, and it's a matter of life and death for Indigenous people. We as a medicine culture have visceral reactions to the idea that we may be participating in racism, that our actions may be racist. They are, and that's what the system was built for. You did not design the system, but you participate in it. And if you can accept the reality that 2 things exist as once, being that we went into medicine to help people and that systemic racism is killing people, then we can work to being anti-racist. We will not make progress if we feel threatened by the idea of being racist. So please, during this talk, take inventory of any internal reactions to perpetuating racism and process those so that you can start, so that you're not starting from a place of defensiveness. Next slide.
Hi, my name is James Liu, and I'm non-Indigenous. I was born in Taiwan, and I've been living and working on the traditional, ancestral, and unceded territories of the Kwantlen, Katzie, and Matsqui First Nations in Lower Mainland, BC. And today I'm calling in from the territory of the Snuneymuxw Nation. I don't possess any lived experience from an Indigenous perspective, and I've worked in rural primary care outreach and remote First Nations communities in central northern BC for roughly 3 years. I've now shifted my practice to focus on emergency medicine and towards integrating anti-racist practices into emergency care. But I'd like to acknowledge that speaking about Indigenous health from the lens of a non-Indigenous person is not an attempt to validate Indigenous voices, as these voices are intrinsically valid and don't require any further validation from persons without lived experience. My main perspective is to share my critical self-reflection with other health providers without lived experience. All emergency physicians provide care to Indigenous patients, and qualitative research has long captured reports of negative experiences amongst Indigenous patients in the emergency department. In addition to poor patient experience, there's also quantitative data to suggest that Indigenous patients receive fundamentally different care in the emergency department. The In Plain Sight report found that First Nations patients are less likely to receive an urgent triage score than non-First Nations patients. And interestingly, it also found that those with lower triage acuity scores had higher admission rates compared to non-Indigenous patients, which raises a possibility that the initial triaging may have underestimated patient need. An older study from 2013 compared geographic areas with higher percentage of First Nation populations with those with lower First Nations populations. And they found that the former had lower rates of revascularization for acute MI, even after correcting for rurality, as well as a number of other factors. And so overall, these brief snapshots of data points contribute to an understanding that the Canadian healthcare system performs disproportionately poorly in meeting the needs of Indigenous patients, with emergency department playing a significant role. And today we'll focus on how we as clinicians may contribute or perpetuate these disparities, but more importantly, how we can play an active role in mitigating them. We'll pass it on to Taylor, who will guide us through a framework through which we'll explore this content.
Thanks, James. Ani, Wasese Bidish Gwanji Ekwe Indigenous Cause. Hi everyone, my name is Taylor. Nimki Benesian Dodam. I'm from Thunderbird Clan, Sagamaka Nishnabek Undunjaba. That means I'm from Sagamaka Nishnabek First Nations near Massey, Ontario. Anishinaabe Kwayandao. So I, as my ancestors before me, am an Anishinaabe woman. I'm currently presenting to you from the traditional territories of the Anishinaabe, Haudenosaunee, Lenape-Wauk, and Chunukton nations. I'm honored to be speaking with you today and to start off by sharing the Seven Grandfathers teachings with you. These teachings are the guiding principles to achieve harmonious living with all of our relations. We've used this framework to structure our cases so that we are approaching in a good way. The Seven Grandfathers teachings surround the concept of Mino Bima Diziwin, an Anishinaabe teaching on how to live the good life. The first, humility, Debaden Diziwin, is represented by the wolf, which says to live the good life, we must acknowledge that we are all a sacred part of creation and live selflessly and equal to those around us. The second, bravery, or Akodewewin, is represented by the bear. It means to live well, we must live facing our fears while protecting those around us. In order to face our lives with courage, we must then know bravery. The third, honesty, Gwakwa Diziwin, is represented by the raven or sometimes the human, and it means to recognize and accept who you are and the gifts that you have been given. The fourth is wisdom, or Nibwakewin, is represented by the beaver, which calls for us to cherish our knowledge, observe the life around us, and listen with clarity while knowing our limitations. The fifth, truth, Debwewin, is represented by the turtle, which calls for us to recognize the importance of the journey and the destination, speaking only to what one has lived and has experienced. The sixth, respect, or Minaden Demawin, is represented by the buffalo. This teaching calls for us to respect the balance in life, share with those around us, and to treat others with kindness. And the seventh and final teaching is love, Shigadadiwin. It is represented by the eagle. According to this teaching, to know love is to know peace with yourself, with the Creator, with the balance in life, and with all of our relations. These teachings will help us today to approach our cases in a good way, as they can help you as well in your daily life. Using these teachings are universal and foundational laws for Anishinaabe people and Indigenous communities as a whole. Bringing the Seven Grandfather teachings into your daily practice can be a way to honor your Indigenous patients and are available for anyone to draw on in order to guide their care. Next slide.
We'll launch into our first case. Thank you very much, Taylor. A 37-year-old Indigenous patient suffered a fall 7 days ago at work. He registered in the ED 3 days ago and was sent for an ankle x-ray by the triage nurse. Upon your chart review, the encounter was closed as left without being seen. And he returns today as he could no longer walk, and his workplace asks that he holds off on further shifts until he's assessed by a physician. Radiology report from the x-ray from 3 days ago shows no fractures. So what's your level of clinical suspicion regarding this patient's injury? So we as emergency clinicians are always considering the degree of clinical suspicion as part of every clinical encounter. Many factors about this patient's presentation might lower our suspicion even prior to formally assessing the patient. And these can include delayed presentation or left without being seen in a prior encounter for the same injury and clinician exposure to a normal test result. So to explore this area, we'll draw upon the teaching around wisdom. Prior studies have captured reports from Indigenous patients of delayed acute care presentations because of prior negative experiences. And analysis of the CTAS data in Alberta have found that First Nations patients were less likely to be triaged as acute than non-First Nations, non-Indigenous patients, raising the possibility that delayed presentation could result in decreased perceived acuity at triage. And this could result in a variety of downstream impact on the patient's care. And these could include things like time to physician assessment, frequency of nursing reassessment, initial nursing interventions, pain management, nurse-initiated investigations, or even the location where the care would take place. So why did this patient leave without physician assessment in a prior visit? If you ask this patient, he would tell you that he wasn't sure whether he'd be seen before he had to leave and get ready for work the next day. And being a shift worker, he felt that he had less control over his time. And missing a shift would also result in direct reduction in income. He also actually received no analgesia while he was waiting, which contributed to his decision to leave. And this isn't necessarily unusual given that there is prior research evidence to demonstrate that racial minorities are less likely to receive analgesia in the ED. And finally, when he was called to go for imaging, the staff encounter there implied that he didn't move quickly enough because he was Indigenous and he was therefore not concerned about being timely. And so after the x-rays were taken, the patient decided that he's had enough and he left the emergency department. I'll pause here to address the use of the term racial minorities. Some of the evidence that inform our understanding of racialized healthcare disparities come from Canadian, American, and Australian studies of majority versus minority races. And this terminology is therefore being repeated here for accuracy when describing these studies, but this is not typically an appropriate description of Indigenous peoples in Canada. The In Plain Sight report was released in BC in 2020 and found that Indigenous patients were significantly more likely to encounter adverse experiences when accessing healthcare. And not surprisingly, Indigenous people were found to be over 3 times more likely to feel not at all safe in the ED setting compared to non-Indigenous peoples. And so knowing this, you go and assess the patient, and he is wearing his coveralls as he had just left his work site. He's frustrated about his ED experience 3 days ago. And here we'll draw on the teaching around respect. So an Indigenous patient may encounter a number of barriers when forming a trusting relationship with a physician. There might have been previous personal negative experiences with anti-Indigenous racism through healthcare or other figures of authority. There might have also been vicarious traumatic healthcare experiences via either family members or even well-publicized cases in the media. The continued impact of colonialism can also create negative reactions to power differential and authority. And so it's therefore imperative not to expect or assume trust from the beginning, but instead we can make earning trust an explicit clinical objective from the very start of each encounter. And so this might start with responding to expressions of anger with empathy and respect, rather than defensiveness stemming from the fact that we didn't personally cause the patient's prior negative experiences. There can also be a sentiment from some patient that they will go through an impersonal and barrier-ridden process in the ED, and they might still not get their needs met. And so some have found it useful to open the encounter with an explicit commitment to help, such as, I'm here to do my very best to help you. We can also consider meeting immediate comfort needs such as analgesia, and we can explain the assessment process in order to set clear expectations and minimize surprises. Here's one example of a quote from a patient sharing their experience of allowing a physician to participate in their care. We might think that what we might have just discussed sounds like usual patient-centered care, and therefore we must already be doing that. But there's actually some evidence to show that we likely are not. When interacting with patients in the racial minority, physicians have poor interpersonal skills, provide less information, adopt a narrowly biomedical communication pattern, and use less participatory decision-making styles. And this altogether results in some degree of patient self-censorship in trying to present in a way that's more acceptable to the clinician. So in essence, we might be providing care that doesn't make people feel particularly cared for. And so to counter this effect, we may need to assume that this tendency applies to us and to actively apply basic patient-centered and trauma-informed practice strategies as we encounter each patient. And on further assessment, the patient fell sideways with an entrapped foot. And after changing the patient into a gown and doing a lower extremity exam, there's proximal fibular tenderness with tenderness along the medial ankle. There's some swelling and bruising around the ankle. An X-ray of the tibia and fibula shows a nasal nerve fracture. And so you explained that you would like to offer immobilization to the lower extremity with non-weight-bearing status and refer the patient to the orthopedic surgeon on call for likely operative repair. The patient did not offer much response to the plan that you've explained. And here we'll draw upon the teaching around love. So it's important to recognize that silence may not necessarily mean agreement, consent, or lack of concern. So some folks may be navigating the burden of history, such as a legacy of colonial structures that have long sought to silence Indigenous peoples. And others might be working through microaggressions or Indigenous-specific negative experiences that they've encountered, including today. And some may actively be working through the phenomenon of stereotype threat, where their communication is impaired because of a fear of confirming anti-Indigenous stereotypes. And so as such, when we're encountering silence, it may be an opportunity to slow down and ask if there are questions, worries, or other people that the patient would like to involve in the discussion. And so when you specifically ask what the patient thought of the plan, he expresses concerns about experiences with anti-Indigenous racism that his family members have had with the surgeon on call. And so you assess this further through discussion, and ultimately the patient would not feel safe being treated by this surgeon. And so weighing the risk of the patient declining follow-up for this unstable fracture, you arrange consultation with a different orthopedic surgeon. Depending on your institution, this might not be easy or even possible, but it's important to recognize that this concern is not trivial. In declining to be treated by this practitioner, the patient is making the assessment that the harm of having an untreated fracture is outweighed by the harm of being treated by a practitioner who they have concerns about anti-Indigenous racism. And this surgeon will be potentially performing surgery on them. And so if we were to change the scenario into a different patient of a different race who declines to see a consultant because they have a family member who's made a college complaint about this consultant for any reason, would we rationally expect that patient to proceed with this referral? So if it's not possible to arrange care with a different surgeon within your institution, you may need to be transparent about this and assist with strategizing with ways to ensure the patient feels safer, such as the involvement of an advocate or family member. And in some cases, it might require some extraordinary steps, such as referring to a different institution. So in preparation for discharge, you provide printed discharge summary with referral information and care instructions. This can be helpful in involving family members and assist with system navigation to support health literacy. You provide a written prescription for over-the-counter analgesics and crutches, as this enables them to be covered by non-insured health benefits. We also provide some opioid analgesics. First Nations and Inuit patients may be eligible for the non-insured health benefits or other equivalent services depending on the job you're working in. And these will cover vision, dental, medication, medical travel, medical devices, and mental health care. So this can be very helpful to take advantage of, especially for those who might otherwise have limited. Departments might benefit from having these information available on handouts for patients and for providers, or even having pre-printed prescription pads for over-the-counter medications. So in summary, we'll take a look at a few key takeaways from the case. So drawing upon the teaching of love, we can find peace and balance. And in this case, balance doesn't necessarily mean the same or full equivalency. So if you saw two patients, each with similar lacerations of the same body part, where one sustained the injury while hiking and the other due to intimate partner violence, you probably wouldn't expect us to use the same approach or the same amount of time for these two patients. And so this is to recognize that providing healthcare that integrates personal context may take more time, and to view this as a legitimate use of time. We'll again reflect on the teaching around wisdom, where we listen with clarity. Systemic racism might not feel racist or overtly discriminatory. It might actually just feel like offering routine care, but this routine care does not adequately address a barrier that applies disproportionately to a specific population. It's important to recognize that our current standard of care and routine practices are associated with the current set of healthcare disparities that we see at a population level. In order to mitigate these disparities, we need to actively provide anti-racist care. And as such, the mere absence of ill will is not sufficient to ensuring equitable care. And so here we'll close on the teaching of respect. I'll pass it over to Taylor to continue on to case 2.
So in our next case, you are a resident physician working overnight in a community emergency department. It is just yourself and your attending physician managing the entire ED. You get a patch from emergency medical services stating that they are bringing in a patient for altered LOC. Next slide. When EMS arrives, you are met by a 53-year-old Cree man who is slurring and difficult to rouse. He has a 3-day history of fever, nausea, vomiting, diarrhea, and rigors. On presentation, GCS is 10. There is a 4x4 centimeter head lac with no other injuries. The patient is jaundiced with significant scleral icterus. Point of care ultrasound is positive for free fluid in the abdomen, and basic labs are pending. The patient's level of consciousness continues to improve throughout the examination, but there is ongoing confusion. When you're reviewing the case with your attending, they cut you off multiple times. You propose transferring the patient to a hospital with more resources to continue his investigation. Your attending rolls their eyes and states, "Why waste the resources? We know these types of people. The patient is clearly post-ictal from an alcohol withdrawal seizure. Just give him a drink and send him home already." Next slide. So let's pause and talk about this. Throughout history, settlers have created an image of Indigenous peoples, one built on stereotypes and prejudice. This image has dehumanized Indigenous peoples, leaving space for discrimination and unfair treatment. Indigenous patients are more likely to be stigmatized and assumed to be abusing substances than non-Indigenous patients. These presumptions lead to real health implications and create a dangerous space within the healthcare system for Indigenous people. Next slide. This case is not to say that there isn't real issues within certain communities in regards to alcoholism and substance abuse. In fact, Indigenous youth across the country are at a 2 to 6 times greater risk for alcohol-related complications, including death, than non-Indigenous youth. However, it's important to reflect that these current crises were not embraced by the community, but were an after effect of centuries of violence, discrimination, and dehumanization. The crisis within certain communities that we see today are a physical embodiment of the harms done to Indigenous communities and the ways that these communities have fought to cope. Teachings around alcohol describe how interacting with the firewater spirit is used as a coping mechanism, but eventually results in dependency. When one interacts with the firewater spirit, they seek to gain something that they deem missing in themselves, whether it be happiness, erasing painful memories, or simply just feeling more confident in who you are. But as with all relations, it's an equal exchange. The firewater spirit gives you what you are seeking, but takes a piece of your spirit in return. Eventually, your spirit no longer feels complete without firewater to make it whole. I share this teaching as a way to humanize the patient that may very well be sitting in front of you. Though we cannot assume that every Indigenous patient struggles with alcohol use, it is important to understand that some individuals do. Having a deeper understanding of why alcohol has been used to cope with trauma in community will allow you to be more of a trauma-informed care provider in these interactions. Next slide. 1 in 5 Indigenous peoples report experiencing unfair treatment, racism, or discrimination from a healthcare professional. It is expected that this number is much larger, as not everyone reports their negative healthcare-related experiences. But really, why is this? Why do healthcare professionals find it so easy to treat Indigenous patients poorly? It is our responsibility to mino bima desiwin, to uphold debwewin, our truth. Speaking the truth is speaking only to what one has lived and experienced. You cannot come into an interaction with preconceived ideas because you have not walked in your patient's shoes. Coming into an encounter upholding this teaching can help you identify biases and prevent them from impacting patient care. Next slide. In medical school, we are taught about the hidden curriculum, the power imbalances in relationships that impact patient care. Researchers have analyzed this and came to determine that the psychological safety of residents has multiple impacts. For example, residents who feel less safe are less likely to report adverse events. The hierarchy of medicine is even more concentrated and holds a weightier impact for Indigenous medical learners. Across the country, Indigenous medical learners have expressed a lack of safety in medical education. Indigenous learners are more likely to experience racism across their institution and feel an expectation to tolerate this behavior due to preconceived hierarchies. Hierarchies are an example of institutional racism and continued colonization. Hierarchical relationships are not in keeping with Indigenous values, teachings, or beliefs. Minaden Demowen, or respect. All of creation, by valuing each other, is one of our 7 grandfather teachings, and sought after from Muno Bima Deziwin. To continue perpetuating a hierarchical relationship rather than one of mutual benefit and learning is to perpetuate racism and colonization, which harms both learners and patients alike. Perhaps this case would not have existed if we all approached our patient interactions with humility. If we brought a curiosity to learn from our patients and the compassion to sit with them, maybe Indigenous patients would have been safe in our hospital systems. But unfortunately, they are not, and we do not approach with enough humility or patience to truly learn from those around us. In this case, our resident physician is in a tough position. There is nobody else on call with them, no one whom they can plead their patient's case to, apart from their attending, whom sits above them in this medical hierarchy. So how does the resident approach this difficult conversation and be an advocate in a system that is meant to silence learners? Most importantly, how will our patient fare if they do not? Humility in all my relationships. Debaden Diziwin. It's about being equal to those around you, recognizing that you can always learn from them, and approaching each interaction with gentleness, kindness, and compassion. If we can all teach each other, then our attending resident and patient are all experts in their own care. We can protect and learn from each other only if we see ourselves as being on the same team. Now we have a choice on how to proceed. Do you advocate for the patient or stay silent and try to support from behind the scenes? I'll allow you to take a moment to make your decision and then we'll conclude our case. So if you chose to advocate for your patient, you pull your attending aside and speak to them privately. You express your deep concern for the well-being of this patient and ask them to consider ordering some basic investigations. Your attending continues to refuse to order anything in addition, as resources are limited and need to be used sparingly. You walk to your desk feeling defeated and slip out your phone. You decide to text your clinical advisor for this hospital and ask for their help. The advisor speaks to his colleague, demanding the patient be transferred to a tertiary care center. Your attending is furious that you went behind his back and over his head, and he refuses to work with you moving forward. If you chose to stay silent, you quietly take care of the patient. You explain to him that you think he might benefit from going to a different hospital. The man does not understand why he can't be treated here, and expresses that he has no way to get to a different center. He seems hurt and scared that he's being denied his care and doesn't understand why. The next time you walk by his room, the bed is empty. You never find out what happens to him, and you lose sleep wondering where he ended up. 3 years later, you're applying for your first job after residency. Your family has been living in and around this community for the past 3 years. Your partner loves it there and even bought a house close by. You apply for your first job after residency in that same community ED and receive an interview. Nervously, you stand outside the interview room before entering to see the panel, and you are met by your old attending, as he has been a member of the board for years. If you chose to advocate, he remembers you. He refuses to have you hired, claiming you start trouble and do not respect hierarchies. You're brokenhearted, but start to look for other jobs. Unfortunately, your old attending has strong connections across the province, and you begin to look at jobs across the country, uprooting your family and selling your home. If you chose to stay silent, the attending physician speaks highly of you. You get the job in your dream hospital, keeping your family in the community that they love. You become the culturally safe provider you thought this facility needed, teaching others how to be culturally competent and establishing a system that protects trainees. You remember the man you felt like you couldn't help and try to honor him by helping other patients. So I'd like you to just take a moment and reflect. If you knew that this was going to be the outcome of this scenario, would you have chosen differently? And if you knew that potentially that the former outcome could have existed in the first place, would you have approached differently? Miigwech.
Thank you, Taylor. Yeah, I want to just thank you for sharing that perspective as a Indigenous medical learner. I'm about 2 years into my practice, and I can feel that internal conflict. And that was, a real scenario I think all Indigenous learners have experienced kind of over and over and over again during their training. And I was taught that you kind of have to play the game to get in the game, talking about choosing staying silent or advocating because of the power that attendings and nurses and other staff members have over you and control over what, even going into CARMs and residency applications could look like if you, go up against people with this power. And just that feeling like, can I live with myself if I stay silent? And kind of that it takes something from your spirit every time that you do, but you can't actively always fight every battle. I was taught by an elder one lesson that I find quite sad, but I actually use still today in my practice, about the recognition that inherently healthcare systems are harmful to Indigenous patients. And he taught me, and I teach this to my patients sometimes, to kind of close your eyes and think about what you came here for, what you need done. Do you need that broken leg fixed? Do you need your heart looked at? Do you need that infection treated? And then wrap your heart with protection and love, and anything that's not going to help you get your goal and get you out of the hospital as fast as possible, you need to let that blanket of protection around your heart bounce it off of. And unfortunately, I still have to use that this day to my patients for when I'm stepping away from their care and I'm worried harm's going to happen to them. So I appreciate your reflection. Okay, let's move on to case 3, our final case. So you hear a code white called overhead, you're the physician on, and you're asked to request they attend the waiting room immediately. You walk into the triage area, and security services are trying to physically remove a 25-year-old woman who's cuts on her face, who's yet to be assessed or triaged. 2 of the security staff members are holding her arms to usher her to the door, and she's yelling and swearing at them to let go of her. Everybody's looking at her. She's not acting physically violent towards anybody, and she doesn't appear to have a weapon. And the triage nurse tells you that she's known to the department and has a violence alert on her chart for previous aggression. They're not sure why she's here. She was swearing at the ED staff and yelling in the triage area. She was asking for the Indigenous Wellness Liaison staff member. She would not tell them why she was there, so they asked security to remove her after she wouldn't calm down with verbal requests. Currently, the triage area is packed and people are waiting to be seen, and there's a lack of privacy. So as a physician, how do you proceed? Next slide. So do you choose to allow security to remove her and tell her she can come back when she's calmed down? Do you quickly make an assessment, certify her, and move to restraints until you can assess her further? Or do you calmly, but with assertion, introduce yourself and ask what she needs? Next slide. So what are the risks of escorting this patient out? So as a result of settler colonial violence, Indigenous women, girls, and Two-Spirit people face higher rates of violence and homicide than non-Indigenous women, girls, and Two-Spirit people. In 2023, Stats Canada released a report that showed that Indigenous women and girls were 6 times more likely to be murdered than other people in Canada. The Missing Murdered Indigenous Women's Report was released in 2019, and it states that the root cause of this violence is due to systemic and deliberate violation and abuses of Indigenous rights. In the emergency department, We have a duty to ensure all patients are discharged to safety. And by discharging an Indigenous woman without knowing that they have a safe place to go, we are complicit in the violence and murder of Indigenous women, girls, and Two-Spirit people. Next slide, please. Indigenous or emergency departments are a source of nervous system activation for everybody that comes through the doors. This is true for staff, patients, and family members. We cannot ignore the legacy and ongoing trauma that colonization and white supremacy has on Indigenous people. People bring their trauma with them everywhere they go, and this includes the emergency department. Hospitals are institutions that reflect colonial settler priorities that have been instrumental in carrying out the agenda of Indigenous genocide through the Indian Act and other white supremacist policies. Indigenous folks are forced to access care in places they are inherently unsafe. This is evidenced by the deaths of Joyce Eschquan, Brian Sinclair, and countless other Indigenous people that have died within our Canadian healthcare system. If this history is new to you, then please take time to learn it, as it is explicitly linked to how we need to care for Indigenous patients. Next slide. So I want to talk about trauma behaviors. Oh, sorry, next slide, please. Trauma behaviors are activated when someone's under real or perceived threat. I want to go back one slide to the latter slide. Thank you. So trauma behaviors are activated when someone is under real or perceived threat. They are ways people have learned to survive and are ingrained into their nervous system. We need to move the narrative from labeling someone as violent and move it towards asking, what happened to you and how can I take care of you? The polyvagal theory explains that there's 3 main circuits that are activated under threat, and how trauma has long-lasting neural changes that affect how the autonomic nervous system responds to these threats. In the emergency department, staff are most activated when we have individuals acting in the middle area with the activation of their sympathetic nervous system. This circuit is one of mobilization and is known as the fight or flight. It creates huge amounts of conflict between staff and patients and leads people to be labeled as violent. People are often looking to either fight their way out of a threat or they leave the department prematurely to avoid this escalation. Healthcare providers, we often react to these behaviors with our own fight or flight behaviors, and in this case, we make the situation worse. Next slide. We know that the emergency departments activate trauma responses, and we understand that the nervous system has taught people to behave in ways that are labeled as violent. So with this wisdom, the first step in violence prevention is to take personal reaction out of it and control your own response. I always tell myself, I don't know this patient personally, so it can't be about me. And for them to be activated, they must be expressing feelings of anger, hurt, or scared. Next slide. So the first step is to control our own nervous system so we don't make the situation worse. I use the STOP acronym. So I stop, I pause for 1 second, take a big breath. And I observe what is going on in my body, the environment, and my feelings. I'm not observing what the patient is doing, but what is happening within myself and what am I about to bring to this interaction? The next step is to proceed with co-regulation. When we show up activated, it'll exacerbate the situation. But when we show up regulated, we can access people. Notice when our body's activated and bring it back to a feeling of safety before proceeding with this patient interaction. I often do this as I'm walking into a scenario that I know is going to activate me. This co-regulation helps bring the patient, security, other healthcare workers back into a regulated state, and how we show up as a physician matters. Next slide, please. The goal is to enter into a relationship with this patient, and to do that, you have to have unconditional positive regard for her. Recognize she's activated and figure out what's going on and what's going to work best for her. So you calmly introduce yourself, you ask the security guards to let go of her, and you ask her where the best place to have a conversation is. We're currently in a packed waiting room. Everybody's looking at her. She's being racialized, judged, stigmatized, which is just adding to her lifelong history of trauma and anti-Indigenous racism. You have the option of going somewhere more open or where there's less people, perhaps a hallway or just outside the door, or finding somewhere private. Sometimes people who live in their sympathetic nervous system actually prefer open spaces so they can easily walk out of it if they feel activated. You also need to offer to bring an advocate. Is there a person of the appropriate gender for them, an Indigenous wellness liaison, or a trusted friend that they want to call? She tells you she was sexually assaulted last night and she's fled from human trafficking and has nowhere to go. Next slide. So now's the time to give power back. We know hospitals are a place where power is taken away, so we need to shift it back to the patient. What does she need at this moment? Does she need somewhere safe, private, food, an advocate, and realize that the relationship is the most important part of her having choice over every step of the way is an objective step in trauma-informed care and results in better patient outcomes. It's her body, her choice, and her care. You need to use your power for people and never over people. All of these above interventions are going to take time. This time is justified. And recognize that this is often in conflict with white supremacist ideologies of efficiency and economic goals, such as a fee-for-service model. But equal time does not lead to equal outcomes. An upfront investment in this relationship will pay off in the long run as we can address her needs, streamline the rest of the visit, and prevent resource-high violent behaviors. We will also see a return on our investment when people feel safe and as though they have a good relationship with the institution and they return for their next visit regulated. Next slide. So after sitting and sharing her story, having something to eat, you step outside as she decides on the next steps she wants for her physical exam and investigations. When you return, she has left the room without telling anyone. You might feel defeated or that the time invested was not worth it. However, you are setting up her next visit for being successful, and this may be the natural history of trauma and sex trafficking. She does, in fact, come back 3 days later. She has new bruises to her face. This time she's brought a friend, and she's for support. And she's able to tell the prisoner she was assaulted and like to see a doctor. She feels more in control because of the relationship that was built last visit, and in knowing that she has the power to control what happens this visit. Next slide. This is the end of our 3 cases, and we wanted to leave some time for questions, so I'm going to keep this closing short. These cases were taken from real moments in the emergency department. Racism is not a thing of the past, and being anti-racist requires tangible actions. We didn't build the system, but we all benefit from it. So take a moment, take a deep breath, and assess what you're feeling. Hopefully there's some discomfort and there's some curiosity about where to go from there. And we're happy to take any questions.
Thanks so much, Kelly, and thank you, Taylor. So we'll go on to have the rest of the session as an opportunity for questions. So if you have a question, please either put it into the chat, or if you could use Zoom to raise your hand, and then I'll send an ask to unmute. And also just, I see a hand up. I just want to also acknowledge and thank Dr. Jennifer Bryan, the chair of the Anti-Racism, Anti-Colonialism Committee, as well as the members of the Anti-Racism, Anti-Colonialism Committee for their support with this grand rounds. And I see a hand up from Krishna.
Hi there, I've unmuted, so I think you should be able to hear me. Thanks so much for the thought-provoking discussions and cases. I work in pediatric emergency medicine, and I was curious for both for the speakers as well as those in the audience, when we're reflecting on trauma-informed care and ensuring that our own reactions don't essentially hasten someone's exit from our emergency department because we're making it that much more challenging for them. I'm curious if others have faced the situation where, in order to feel for your staff and employees to feel supported, what they're looking from you as the leader of the department is a very different, like the support looks quite different for what staff support is perceived to be, and really feeling that pull of how to support the patient and family, yet also support your staff, whether it's feeling intimidated, physically, verbally, because I find that is more and more of a challenge for me in my practice. And I'm just curious if other people have felt some of that pull and how they have managed those challenges.
I can maybe start. That's such a good question. And I want to, when I talk about my interest is in kind of violent reactions and how we get to those points. And I'm being really clear, condoning violence is not the same as understanding why someone may be acting that way. And it also doesn't, doing the STOP acronym is not going to help you if there's a weapon or an immediate threat. And I just want to be really clear that you have a right and we need to protect ourselves and we get to go to work and be safe. I have observed, though, because I do some family medicine that has a lot of crossover to St. Paul's emergency, which, just like any emergency, we have a lot of violence. And I have a lot of patients and I see them and they're activated and, they have violence alerts on their chart of the emerge. And then I see them in my Indigenous-led clinic, and that is not the case. So I find it quite interesting of how somebody can walk in the door and be activated. And that comes from, years of relationships going south and being not taken care of, and family members or themselves having direct harm or dying, that they come in keyed up. So how do we really be, upholding and reflecting on why someone may be harmed when they come to us and why they might be acting in a way that's self-protective. And I find right, because sometimes you already walk into a situation and it's at revved up, you know what I mean? How do we shift that really quickly? Because we're also in the emerge and we have to sometimes, things are cooking.
It's interesting because I think, as much as we ourselves as, staff physicians might try to manage our reactions, I'm just reflecting myself, and I don't have an answer either. And I don't expect really anybody to. It's more just to really open the dialogue, because it's so interesting just to think about, people will say things like, we can't let people treat us this way, us meaning, the department and staff, we can't let people get away with speaking to us this way, so it's really interesting just trying to manage all these different facets of our positions and roles, and, advocate for all the different people that we are supposed to look after, in one shift. And I don't have an easy answer, but, I do my best.
I think there's a difference between when somebody talks to a patient and says, you have to calm down or you have to leave, you can't talk to me like that, versus, hey, Joe, I get this is really hard. I'm here to help you, but you cannot speak to the nurses, the care aides like that. I will not tolerate, violence and aggression. If you want, you can take a step outside and come back. I'm happy you're here and I want to take care of you. However, we need to all work together. And that the second one comes from a place of I'm understanding, I'm not condoning, and a place of unconditional positive regard for this patient. Because there's also, Indigenous laws that talk about, mutual respect. And I do ask people to come into a place where I work and treat me with basic respect, and not tolerating being called names or intimidation is different from dehumanizing someone and saying you're a violent person, everything's on you. Does that kind of make a bit of sense? And I'm happy for anybody else to jump in.
I think it is really helpful, and I think that piece of reminding people, even if they're if you're being spoken to in a way that doesn't feel supportive or great, that you're still very happy that they're here, because in the end, we want to make sure that we're giving good care. I think that's an important takeaway. So thank you so much.
I think if I may also share my response. I think several things. One is, I think all of the points that Kelly had mentioned around trauma response applies in terms of helping to what I sometimes call social critical care, where like I'm walking into the room and as a tune I am in the resuscitation room where I'm responding to every vital sign abnormality, responding to every subtle appearance of the patient. I am pretty much doing the same thing in interacting with that patient and engaging. But in this case, I'm trying to actively avoid contributing to harm or escalation or worsened relationship. And sometimes I find that I think the point that you're speaking to, sometimes the nurses, like they didn't want to feel supported as you were mentioning, or the staff, they want to feel safe. And I think that those are valid wishes. Sometimes what can happen is we were mentioning earlier that sometimes, addressing comfort care needs can be very, very instrumental and can very much help the patient understand that their needs are being met. But I sometimes find that if then I'm asking for the nurse's help to say, can we have a warm blanket or can we have food? We're taking staff who already feels threatened or they have had a negative interaction, and the staff might take that and feel like, oh, so I didn't feel respected, and now you want me to go offer a blanket or you want to offer some food. I mean, yes, that's part of our job, but sometimes to take away that reaction altogether, I do those things myself, and I bring the food, I bring the blanket. We begin to hopefully start to build some have something to work from. And sometimes what I feel is that the support that the staff needs sometimes is in the result and in the outcome, in that like when the patient becomes a bit less activated, that kind of meets the expectation of the staff, and they can kind of carry the conversation forward. And so sometimes at this point, I then bring the staff with me and say, and kind of introduce them and almost do a warm handoff and care with a patient that's a little bit less escalated. And from there on, when the staff sees that I'm able to stand within arm's reach of the patient and have a warm conversation with the patient, and the patient is responding to that, sometimes it can be helpful in changing the tune, but I don't need to make the staff feel like they haven't done that. And this is why, we're in the situation that we are in. And finally, sometimes I just say to the patient, the most important thing is that we want you to feel safe and cared for. And the staff here have the same need. While they're working with all of the patients here, they also need to feel safe. And so we need to be able to work in an environment where needs are best met when everyone feels safe. So are we able to, I just ask for your help so that as well, so that we can all have everyone feel safe, and that will make the care go the smoothest and the best. And sometimes that can't be enough in hopefully diffusing the situation without finger pointing. And this is likely, and as you said, this is probably all things that many people have tried before. This isn't particularly new knowledge, but hopefully hopefully, as you mentioned, opens a dialogue.
Thanks so much. I appreciate it.
Just picking up on a note from the chat here. So from Jennifer, thinking of the learner in the earlier case, deciding whether to stand up to their staff or stay silent. What advice do you give to learners faced with that dilemma?
I can start this one off because I feel really grateful for the teaching that Kelly shared. And I think that's a teaching that a lot of students have received, of that moment of just protecting your heart. And going into each interaction with your heart protected, because there is inherent harms in medical schools towards Indigenous learners, and that's what we know. I think the other recommendation has always been to find your community. Indigenous medical students and residents tend to build a community for themselves in different medical schools in order to stay supported. And I know for me personally, it's been someone that I can call when and if something has happened in school or we've experienced an overt racist remark. You know, there are people that you can call that you can cry with and laugh with, and those are really the people that you lean on in those moments. But I think that the real root of this question is that why do we have to have our students, and why are our students expected to try to make themselves safe and to have and control their reactions to unsafe moments in medical school? You know, the real question should be, why is there still staff physicians working with learners that are being unsafe towards them? And I think that that's really the root problem that we have here. And approaching with our 7 grandfather teachings, you know, Minadendamo, and approaching with respect for each other and on that mutual playing field is really going to take out that hierarchy that's not Indigenous at all, and try and help us create a more balanced atmosphere for our learners. So I think that there are things that learners are doing to stay safe, but I think that it is in general unfair to ask them to try and make themselves safe in a harmful institution. And that's really the root cause of that problem.
Taylor, that was so exactly spot on. I remind learners that their job is to learn, and sometimes you have a situation and you have to sit with it, and is it making you uncomfortable because you absolutely need to do something? It's patient safety, or it's a terrible situation, a reality of what's going on in our healthcare system. And unfortunately, you have to pick between the two, because there are some times you have to, but there's also times when you're learning. It is very okay to not, you know, fight that battle. And I tell them that. And people do a good, you know, Indigenous, just by being there, you're helping that patient, you know, you're getting that patient and having a conversation with them and being a safe person. You are already providing positive, good care. And the system is not your responsibility at this point in your training. And everything does not fall onto one person. And I kind of teach that to learners, that they don't have to be responsible for everything. Just like I'm not responsible for every Indigenous patient that comes in, say they emerge. Like, you do your best and you do your part, and you expect others to do it too. I think Joanne had a couple points. I know we have a couple seconds. I'm just
I'll
reading it.
read off what Joanne says here. I find it hard to use "I understand" in these situations as a white person. And so for example, I understand that you are upset or angry. And the question here is, for example, I see or I hear from you, would that be effective?
Yeah, I think sometimes you know, like when I introduce myself as a Métis physician, that's like, and I can enter a relationship easier than non-Indigenous physicians. So I recognize this, and I really appreciate that question, that reflection. I think you could also add to it, like, you could name why they're frustrated. You know, like, this healthcare system causes harm. We're in a white supremacist healthcare system, and that names it, as opposed to saying, I understand, and when you don't have a similar lived experience. And I think that's what you're getting at. So I often just name it. I get it. You're mad. We're in a system that's not built for you, and it's been a really hard day you coming here, and I'm so glad you're here. I want to take care of you, and please, if there's anything I'm doing or not doing that you think I should do, let me know. So I just am very honest, and I apologize. I don't know if James or Taylor has anything to add.
Okay, that sounds good. I'll just maybe add on to the previous point around what Taylor was speaking to as well. Sometimes engaging additional people into care, such as family members or the liaison in some cases, or even if it's any basically these different avenues might just increase the safety in numbers sometimes if appropriate. or if in any case, just having the patient feel like there's someone bearing witness, or for the learner to feel that there is someone bearing witness that can potentially help increase safety, even if it may or may not necessarily directly change outcome. I'm conscious of the time now where we've reached the end of our time. We have our emails up on the slide here. Please feel free to send us an email. And thank you again very much for your time and your participation.